moderators. I'm honored to be here, both for this conference, for this session, but also for this meeting in general. It's been extraordinary just this first day. I'd like to speak today about heart disease in women, which we used to think was something that we worry about as women got older. But now we know that we have an opportunity at all stages in a woman's life to have an impact on better health outcomes. So just the most recent data, unfortunately now stroke and heart disease, ischemic heart disease, have become the number 1 and 2 causes of death in China, as these are almost throughout the world. Stroke a bit higher in 2021 than in the years past. If we include hypertensive heart disease as well as kidney disease, you can imagine what an enormous burden this combination is here in China. Looking at changes from 1990 to 2021, we see that there's been over a 100% increase of deaths in cardiovascular disease in China. And although this data seems very depressing or aggravating, we can also see it as an amazing opportunity to improve health. So today, I'd like to speak a bit about unique factors associated with cardiovascular disease across a woman's lifespan, identify opportunities to enhance prevention and early detection in women, and to understand the importance of collaboration among subspecialists to improve heart and brain health in women. This important Lancet publication that came out in 2021 defined the fact that cardiovascular disease in women remains understudied, underrecognized, underdiagnosed, undertreated, and still to date, women are underrepresented in clinical trials. A recent publication in JAMA Cardiology, looking at participation of women in cardiovascular trials between 2017 and 2023, still showed a continued low participation of women in trials, particularly in ischemic heart disease, heart failure, and atrial fibrillation. This slide, also taken from the Lancet work, talked about well-established risk factors in the lower left. And you see, we know these: hypertension, dyslipidemia, diabetes, obesity, etc. And even though these are traditional risk factors, we have learned that some of these risk factors are more potent or more important in women. On our right, we have underrecognized risk factors that include psychosocial risk and other issues more prevalent in women. But in the top left are what we have discovered over the last 15 to 20 years of sex-specific risk factors. And these have become extremely important opportunities for us to learn more and impact on the health of women. I like this cartoon because it talks about sex-specific risk opportunities from young women, early girls, and even younger, all the way up to our older women. And at each stage in a woman's life, we have new science showing us opportunities to improve health outcome, as well as for women, the overlap in non-cardiovascular conditions that may have an enormous impact on health. We've learned from a physician named David Barker that even in utero, when a mother is carrying a baby, there are opportunities that we call fetal programming, or Barker's hypothesis, which talks about epigenetic changes that can occur in the fetus if the mother is not of good health. And we'll talk in a few moments about the importance of reproductive age in a woman's life to really optimize cardiovascular wellness, not just for her, but as we've learning from some of this epigenetic work for the children. We have learned that intergenerational, from mother to fetus, transmission of diabetes to offspring has been shown. Some very important work that looks at women who are overweight during pregnancy or have abnormalities of their blood sugar, and how this increases the risk of gestational diabetes in offspring, as well as type 2 diabetes and other metabolic concerns. Now we get to our girls, our youth. We know, even if it's not something that we can change, that either early or late onset of menstruation, the first period a girl gets, puts her at higher risk, either younger than 12 or over 16. We know that girls with menstrual cycle irregularities are at higher risk for certain forms of cardiovascular disease. A first pregnancy under the age of 20 has been shown to increase a girl's risk, as well as two important conditions that we're learning more about: endometriosis and polycystic ovary syndrome. Polycystic ovary syndrome is an abnormality that begins with hematopoietic progenitor cells and ultimately is a hyperinflammatory state that has changes both in endothelium as well as in myocytes. But we think of it just as a young girl with abnormal menstrual periods. And in the past, we know as many as 1 in 10 girls throughout the world can have this, and we've only now done some amazing work to identify how this impacts on cardiovascular health, and particularly what we can do for young girls. It is the most common endocrine disorder in young women. It is usually defined as abnormal ovaries on imaging, unusual periods, chronic anovulation, menstrual periods without, and hyperandrogenemia, often seen with hirsutism or hairiness. We've shown that there's a higher risk of coronary disease as well as more extensive and hypercalcific coronary abnormalities. There is also obesity, type 2 diabetes, and other dyslipidemias. We sometimes think of it as a risk enhancer, but probably with more work, we can hopefully define this as a true risk factor. Now going to the pregnancy ages, reproductive ages. This is an amazingly important time in a woman's life for several reasons. First, she is seen by a clinician more commonly than she may have been. Much testing is done on the mother and fetus. But we know that during this time period in a woman's life, there are many adverse pregnancy outcomes or many markers that define a woman at higher risk. Infertility has been shown to be linked to higher risks of cardiovascular risk factors and CAD. Premature ovarian failure, either less than 45 or less than 40, often seen for no good reason, but most likely, at least in the United States, in relation to cancer treatment. Breastfeeding has been shown to protect against cardiovascular disease. Other adverse pregnancy outcomes: small for gestational birth, repeated miscarriages, gestational diabetes, all forms of hypertensive disorders during pregnancy. Rheumatologic conditions, lupus, Sjogren's syndrome, which are often seen in this age woman. We're learning more about sleep disorders and postpartum depression as important markers. We often call pregnancy a metabolic stress test because we all know the physiologic changes that occur during a pregnancy as blood volume increases, SVR changes, insulin resistance worsens, and there are populations of individuals who have adverse pregnancy outcomes, and this puts them as marked for having a higher likelihood of early hypertension, diabetes, and ischemic heart disease. This is a wonderful AHA scientific session statement that looks at 8 POs, adverse pregnancy outcomes and cardiovascular risk. And the wonderful title is that this is a unique opportunity for disease prevention in women. And as we say, what happens in the pregnancy period can't stay there. We need to, as clinicians caring for women, know this as a very important part of the history. Hypertensive disorders during pregnancy, I'll mention just quickly, with an ideal, with the goal of allowing women to enter pregnancy with optimal cardiovascular health. Every month of breastfeeding after 6 months equates to a 10% lowering of lifetime risk of cardiovascular disease. So for the many reasons that we recommend breastfeeding, cardiovascular health is one of them. This is a busy slide, but suffice it to say that a history of infertility or a history of null apparis with pregnancy losses, in other words, either not delivering a live child with or without a pregnancy loss, identifies women at higher risk for lifetime cardiovascular disease. And again, it's important to ask this history, even if a woman comes to our office in her 50s or 60s, as we put together a risk history. Turning now to midlife, I'm not sure I like that term, but this is an opportunity in a woman's life to really focus on cardiovascular risk, traditional and sex-specific factors. Menopause is a very important time for a woman. We know, of course, that menopause does not cause heart disease, but it's a time with rapid flux and ultimately dropping of estrogen that women develop more evidence of diabetes, hypertension, other forms of hypertriglyceridemia, weight gain, sleep disturbances. Even things like vasomotor symptoms, the night sweats and symptoms like that are signs that we need to identify these women. The whole discussion of menopause hormone replacement or hormone replacement therapy, as we called it, was something that was started and stopped in the 90s, but really has become an important area of research. I'm going to mention a finding on mammography called breast arterial calcification in a moment. And we know that sleep disorders are important. Busy slide, a tremendous amount of work about menopause accelerating heart disease, the importance of vasomotor symptoms, and even depression and sleep disorders that are seen during this period in a woman's life are important not to ignore or minimize the symptoms. Dr. Thurston from Pittsburgh in the US has done an amazing amount of work on shorter sleep times and sleep disorders during menopause and how they relate to increased plaque. We know that primary prevention of CVD is not recommended, the use of menopause hormone treatment. But we do know in more recent data from the original Women's Health Initiative that there is no apparent CVD risk in women given menopause hormone therapy close to menopause. I think this is an important opportunity for us to study the science better and to be better accustomed to speaking with women about these opportunities. This is a wonderful paper from Leslie Cho at the Cleveland Clinic and a green, yellow, and red light approach to how we identify individuals who are at low, middle, and high risk for hormone replacement. Breast arterial calcification is something that can be seen on routine mammography. All machines can identify this, and in the past we ignored it. And so we think that this may be something, and data shows that this may be a free way during a woman's annual or biannual mammogram. These are calcifications within vascular media. They are not intimal thickness. They are calcifications that can be seen in muscular arteries, but they seem to identify women as an additional, potentially sex-specific risk factor. BAC prevalence exists in normal population. It is more likely to be seen in older individuals, and it is increased with age, hypertension, and diabetes, but interestingly, not with smoking. Finally, we turn to our older women. We want to know their history of reproductive or other pregnancy outcome issues that were unexpected. We want them to look at chronic conditions. And we have learned that frailty, sleep disorders, and social isolation in older women increases their risk for cardiovascular disease. The burden of cardiovascular risk factors among older women is higher than among older men. And this study looks at acute coronary syndrome and geriatric syndromes and the overlap between the two. Frailty, defined as unintentional weight loss, weakness, low activity, has been shown to be highly prevalent in women, particularly in those with heart failure. Women have less muscle mass, more bone and joint disturbances, less focus on vitamin D, and exercise for older women feels prohibitive. Lastly, there's been a lot of data about social isolationism, and particularly seen in older women. not being part of a community, of a neighborhood, living by yourself has become something that we see is much higher in women and much more dangerous. So in summary, heart disease for all of us in the world remains the #1 killer of women. The unique opportunity of lifespan milestones for us to study and impact on our women is critical. Collaboration among specialists, whether it's a diabetes specialist, a pregnancy, a gynecologist, obstetrician, even the breast imager, can really work together to optimize women's health. And finally, improving cardiovascular health in women is an unmet need and a very important opportunity for each of us to answer as yet unanswered research questions. Our Go Red for Women movement internationally, now in its 21st year, has had an enormous impact as we collaborate and work together on raising awareness of our women and our communities, identifying scientific opportunities, and collaborating on advocacy and access. Thank you very much for your time.